Hello, ladies and gentlemen. I am O'Brien McMahon, and this is People Business. In this episode, I'm joined by Dr. Bipin Mistry, Chief Medical Officer at Alight. Dr. Mistry is board certified in internal medicine, and he obtained his medical degree at King's College of Medicine and Dentistry at the University of London. And he also has an MBA from Babson College. He is passionate about value-based care and issues connected to the advancement of health equity. In this conversation, we go deep into the healthcare system, and we talk about what is wrong with the current system, what is wrong with the way that employers are structuring their health plans for employees, and what the future looks like, where the healthcare landscape and the employee benefits landscape is evolving, and how to actually get employees and individuals to the right care at the right time for their specific condition in a way that meets their needs, their lifestyle, very specific to the individual. Really interesting conversation. We do go deep into some healthcare terms and everything that he talks about in the beginning. So bear with us. We do explore everything, but the healthcare system is a beast and it is very complex. And I think Dr. Mistry does a great job of breaking down the pieces and talking about what employers, health plans, and individuals can do to maximize their care. Without further ado, here is Dr. Bipin Mistry. Dr. Mistry, welcome to the show. Very excited to have you on and cover some employee benefits topics and healthcare topics today. It's as somebody who spends my professional life in the healthcare space, I've kind of avoided these topics. I didn't want to make this like a sales show for what I do, but I do think it's important. I think it's a big part of managing people in work is managing not only the benefits plans that you offer, but helping people manage their own health and healthcare, because it takes up so much time and energy, and healthy people are more productive and happier people. So I think the topic's going to be really relevant, and I'm excited to have you on today. I guess to start, would just love to have you introduce yourself. I'd love to know, what is Alight and what is your role there?
Sure, Brian. Thank you for having me. I think this is a very important topic that we're going to be discussing. So I'm Bipin Mistry. I'm Chief Medical Officer at Alight. Alight provides solutions around the health, wealth, and well-being of individuals and work with large employers. And my role as Chief Medical Officer in the company is focused primarily on the healthcare navigation strategy piece. And this is really sort of developing the digital navigation that sits on top of a human-guided navigation experience for members. And as part of that, I really want to sort of think about how we use data and insights to drive and develop personalized journeys. And this involves working with data scientists folks and using predictive modeling. And other things that I get involved with include helping with client and support sales, and really sort of looking at, what are our existing solutions? How are they helping members, and how can we improve on them? So that continual learning process. And one example that I've recently been involved is a topic that's near and dear to my heart is trying to find that high quality provider, and how do we create that recommendation for the member for their needs, not just because we need to get a doctor for them. And ultimately, I think the bigger goal for me is to really help employers optimize their healthcare ecosystem and make it more member centric and get the value that they expect from their carriers, their point solutions, etc.
Fantastic. And there was, in that 2 minutes, there's a lot that we're going to unpack over the rest of the conversation. So there were some terms you threw out. I'm actually going to hold off on having you define some of those. I think we'll get to them as we go in the conversation. So if you're listening, stick with us. We'll get to unpack everything that he just said. But let's start, I guess, just with the healthcare ecosystem in general. Over the last 15 to 20 years, employers have been seeing their healthcare costs go up. Employees have been seeing their healthcare costs go up. We hear about medical inflation all the time. What is the current state of the healthcare system as you see it, and why do the costs keep going up the way that they're going up?
Yeah, I think there's multiple factors here. I think the cost of supplies and the healthcare systems themselves have had tremendous problems since COVID. Certainly these last 2 years have really exposed these big gaps that we were kind of not really wanting to pay attention to. And so these gaps are really sort of making sure that, we're getting the right care at the right time, and it's at the right site of care. So in order to do that, there's been some changes in the healthcare system, which does cost money. The other factors that really start to play into the sort of escalation of healthcare costs, that, if we take a health system, they're currently going through so much problems of staffing. And so they're using a lot of per diem locum staff. And so that's driving up some of their internal expenses. From a macroeconomics level, there's been a lot of consolidation in the healthcare industry. And that's led to sort of their ability to demand higher prices. So you can start to see sort of that game playing out. And then, of course, inflation is always going to be a factor here. I think there have been advances in medicine and pharmacy, which have been good, but, there's obviously increased expense as a result of that. And then, just the way that the healthcare system is being delivered, it's driven on volume. And so, based on that theory, people just deliver care based on quantity and not necessarily tie it to quality or outcomes. And then there are softer factors that people worry about, the fear of malpractice. And so people talk about defensive medicine and people ordering tests so that they don't miss something. And the reality is that, one should really think about, what is the evidence for ordering that test and being appropriate with the care that's being given. And then I think the final piece is that, as employers, they rely on folks to help make decisions around, which health plan to choose. And often the employee may not actually have their needs met through the health plan decisions that have been made at a macro level. So there's a couple of factors that kind of just drive up. And some of the ideas around the plans are like, the high deductible plans have been increasing over time. So, a lot of the expense has been pushed onto the employee.
I want to talk about the volume piece of that for a little while, because I don't know, we're not going to solve that here in the next hour or so, but that is a big problem that we see is, it's not a healthcare system, it's a sick care system. You've heard people say that it's just all about treating the sick. There is, or it seems like we want to make a shift away from that. Where are we in making a shift away from that type of a structure? And where do you see that going, and how fast do you see it going there?
Yeah, great question. So people talk about moving from volume to value-based healthcare. And really, this is sort of moving the concept of a fee-for-service model to a more value-driven model, value being outcomes and quality over the cost of care delivered. And so we've seen programs develop from a national level through CMS, where for the past 10, 15 years, they've really been trying to drive some of this through things like Medicare Advantage plans, where it's a capitated model, or bundle payments, where you pay for an episode of care and you hold the providers and the care system accountable for that management of that patient through that period of time for that, whatever that condition is, with some risk involved. And then you've seen population health-based strategies, such as the accountable care organizations. Now, this great on a Medicare perspective. How do you translate that to an employer situation? So we're seeing some of that through bundle payments around surgical conditions, for example. That's prevalent in the employer ecosystem. And you've got a number of companies that will offer those services where they go out to negotiate best prices for conditions and steer and help members to that high quality surgeon if they need to have that particular procedure. Population health, however, is somewhat difficult to be managed on the employer side. We do see some schemes around employer-sponsored primary care, which I would equate to a capitated model, meaning that the primary care team are paid on a per member per month basis and have to try and sort of manage that patient member in their primary care and healthcare needs for that year. Those are good, and most of them generate savings. But then the ideal strategy one would want to take is like a global population health strategy. And that one's difficult to achieve on the employer space, because there you have to start to sort of think about, what is it that I'm trying to achieve for the population? How am I going to stratify the population? What are their needs? How do we organize care around those population segments? And then how do we coordinate the care that lead to savings? And then the question ultimately at the end of the day is, the savings, can they be shared amongst the people that are participating in managing that population care?
Can you define population health management and maybe even give an example of like what an intervention would be or what a strategy would be from a population health management standpoint?
Sure, yeah. So this is population health strategies are really sort of rewarding a group of providers for meeting population level targets. So, and the aim is really to drive sort of patient-centered care for that specific population. So let's say we have an employee population that has diabetic patients, people with diabetes. Some are well controlled, some are not so well controlled. So the idea here is that you try to bring together resources that make sense to manage that population. So that could be human, could be in the form of nurses, dietitians, and then obviously some physicians, and then behavioral health folks. Because, having a chronic disease has a lot of effect on one's mental health. So, that can certainly drive how people are engaged in that illness. And then using that sort of concerted team-based care, you try to engage the member and try to improve their healthcare literacy and understanding of their disease. So in this case, for diabetes, making sure they understand the importance of managing their sugar, importance of diet, importance of exercise, and then, making sure that they, to manage diabetes also involves, regular visits to a clinical team. Doesn't always have to be the doctor, but it could be a check-in on a regular basis with the clinicians. Maybe it's a nurse, maybe it's a nurse practitioner. And they really are there to help sort of guide and advise the member. And then if there are tests that need to be done, that they can be ordered, and then they can follow this sort of trend of that healthcare illness. Now, in addition to sort of the human support, there are things that digital solutions that are out there that help store the information about someone's blood sugar level. So there's blood glucose monitoring apps that show how people are trending with their sugar. So that helps the clinician and the team help intervene or engage with the member at points where it's starting to show a trend in the wrong direction. And then finally, as with any healthcare condition, there are factors that may be barriers or maybe issues that may prevent the member from receiving the care. So we have to sort of identify those, what I call social determinants of health. So
I was going to ask you about that. Yeah, that was my next question was like, so I guess if you could define social determinants of health, and then what is the tie between population health and social determinants of health? Are they two sides of the same coin, or are they different things?
Yeah, I think that, they're definitely a factor in managing a population. And so examples of social determinants of health could be food insecurity, financial issues, transportation, to name a few. And the idea here is that, people may have transport issues. If we take that as a good example, like getting to a specialist for their diabetes, let's say in our example, they may not be able to get to the doctor's visit. So, have to try and figure out, how can we improve the access to that specialist? Maybe it's a telehealth solution. Maybe it's part of the plan is a contract with these companies like Uber and Lyft, for example. And you see that in a lot of programs. And then there's issues like, the cost of the medicines. So in this case, for diabetes, neuroagents are quite expensive. And so, people don't know necessarily how to navigate that. So having somebody take that load off and try and investigate and figure out what's going to be the most cost-effective way of getting the medicines is going to be very important. I talk about mental health, and I think that some of what we try to understand is, anxiety and depression in these populations, and trying to see if there's ways we can help the member on that front as well. And then, of course, there's solutions that the employer has, whether it's EAP or behavioral health solutions that we can tie the member to so that they can at least get some additional help. So these are examples. Food insecurity is very interesting as well. I think, food is access to healthy food is the key here. And as we all know, sometimes that can be expensive, or that my local options just do not provide that healthy food. So, how do we move down that pathway? And you're starting to see, food as a medicine coming up as a a problem that we're trying to solve for, as not just as a nation, but also for employers as well. And so you're seeing some companies pop up that can help sort of address that food insecurity or healthy food element of trying to provide good holistic care for a member. And it's really important, I think, for like diabetes, because what you take in is going to affect your sugar, and ultimately, if it's not controlled adequately, you're going to accelerate complications, which is really not what we we want for the individual, because those complications of chronic disease can be quite severe, painful, and life-threatening.
Yeah, you had sent me the article that you wrote on food as medicine, and it really is, right? Food is the first form of medicine, because what you put into your body is what's either going to nourish it or lead it down the wrong path and create health issues down the road. So I think that is an interesting way to think about it. It's not a way that hardly anybody thinks about the food that they're eating. So you had mentioned high deductible health plans. And when you talk about everything that you've talked about here and trying to get people to better care, higher quality care at the right time, we hear a lot now, I say a lot now in meetings, driving employees to the right care at the right time. Consumerism, which is sort of the underlying theory behind the rise of high deductible health plans, was meant to address that problem. Right? It was, we need to create better individual consumers. We need to turn our employees into better consumers of healthcare, give them some skin in the game, which is the high deductibles, so that they're on the hook for more of the cost up front. And then they'll go out and they'll make better decisions because they don't want to spend money fruitlessly. And so they're going to become smart consumers. We're going to create this wave of healthcare consumers out there. How has that worked? And like, what do we know about that now compared to what the theory was maybe 20 years ago when it started?
Yeah, I mean, I think on paper it sounded the right way, skin in the game as you described. But how can you have skin in the game when you don't understand the healthcare landscape? When there's no cost transparency, there's no idea of what is quality, what am I getting for my services? I mean, the commercial sense of consumerism is to, provide value to what you're getting from a goods and services perspective. And we don't really have any clear way of defining that. So I think that that's been an issue for individuals to actually go out there and try to understand how they can manage their healthcare expenditure. And to that end, it's created some perverse incentives. People have tried to
expand on those.
Yeah, so people will start to look for, the high deductible plans will it's a game of trying to get to that point after which, the carrier will start paying for things. And the reality is that you want to remove some barriers that allow for routine care. So I think, the design of high deductible plans really should be for those situations where someone's having a serious or going through an emergent or going through a surgical issue. But the high deductible plan really shouldn't be a barrier what I'm trying to say is that, we should be encouraging preventive care at no cost to the employee.
Yeah, it shouldn't be a barrier to the routine care.
Right. And I think that's exactly, and I think that's where we miss part of with the high deductible plan is that it's just not steering us in the right direction, which is a preventive care. And I think, you going back to sort of the cost transparency and having choice, people really, it's hard enough for people in the healthcare profession to understand what the costs of care are, and let alone, the general public. And it really makes no sense to me when we start to think about healthcare, because it's such a quagmire. In what other industry does it make sense that, like, for example, why should an MRI cost 4 times as much depending on where you go? I just don't understand. It's the same procedure. It's the same use of electricity, technology. Why should it cost 4 times as much? And that's where I think we lose when we're trying to drive consumerism in healthcare through a high deductible plan. So I think, in my opinion, I think they're needed from a financial perspective, from the employer perspective, but I think it needs to be designed in a way that drives the incentives in the right direction for the individual employee.
If the consumerism model isn't driving better care, what's next? Like, what's our next theory on how to get people to the right care at the right time?
Yeah, I think it's a combination of providing that unbiased and trusted information and providing the tools and resources to individuals to be able to better understand their healthcare journey. And those resources can take the form of digital as well as human, and having an element of what we call navigation applied to the healthcare journey. And it has to be done in a way that people understand that it's meant for them and that it's individualized, and that we're trying to drive the outcomes that matter to that individual, because that's going to be really important. Some people, may view a particular orthopedic surgery just as a way to get rid of pain and be able to walk around. Others may view it that I want to get back to playing golf or playing tennis. So, we've got to sort of make sure that we understand where the member is coming from and where they're headed to, and trying to get them to that point with the best information and the best quality of care and the appropriate care that's going to drive the outcomes that they desire.
So how do you define navigation then?
Yeah, so navigation, the way I look at it is in a couple of layers. One is just simple navigating the benefits that your employer is offering. So this is really at the time of open enrollment, getting people to understand, their healthcare options as well as the well-being solutions that are being offered by the employer. That provides an opportunity for engagement of the member. So if there are gaps that we see that the member doesn't have a primary care, it's an opportunity to encourage them to choose a primary care. So that's at the very base level of navigation. And then you start to move up to sort of more and more advocacy and healthcare navigation models. So starting with advocacy, this is really just trying to overcome barriers for the members. And often this is tied around understanding some of the benefits, trying to address some of the social determinants of health and any gaps in care that, or if someone's having questions around their healthcare journey and it's very simplistic in its model. And these are often like bolt-on solutions to carriers. And then the carriers have some responsibility of doing some of the navigation, but some of the way they do it isn't quite member-centric. So, the case management, for example, in carriers is, it's often to try and avoid the high-cost claimants hitting the plan. And so they can address some of the gaps and help people along the healthcare journey. But it's really those people are already in a healthcare journey that's heading towards an expensive journey. So it tends to be focused around particular high-cost claimants. And then you have healthcare navigation models that are really sort of trying to develop that more robust clinical and non-clinical guidance. So from a non-clinical lens, this is really sort of helping the member find a doctor, helping the member between visits, helping the member through issues that they may have with billing or claims, etc. And then you have the clinical component. And this is where it really is important that we become that trusted source of information. So when I look at clinical healthcare navigation, it's really sort of helping the member in their healthcare journey, wherever they may be in their healthcare journey. But they still follow what I call 5 key tenets. One is that, is the diagnosis right for that member? And do they understand their illness? What is their level of healthcare literacy? And do they have the medical decision support as they embark on their journey, wherever they may be? Are they seeing the right doctor for that condition? And, if they don't have the right doctor, can we help them find the doctor that provides that evidence-based care? It's not uncommon to see that some physicians may view a solution to a problem as always being surgery. And that's not always what's needed. So that leads to the treatment. Is it the right treatment that the member's getting? And that's where, having services where we provide sort of medical decision support, or even in sort of rare or complex conditions, expert medical opinions, to make sure that the member's getting the right information and that they're getting the right treatment. And then the fourth element that is really important for a member is that facility that they're going to, let's say for surgery, the best facility to go to. What are their complications rates and the standard of care, etc. So that's going to be really important. And I think the final piece, which is probably pivotal and key, is how do you help the member cope? How do they cope? How do their loved ones cope with their healthcare journey? And then there's some unmet needs that we can anticipate. And this is where we sort of ask questions around social determinants of health or their anxiety or depression level. And then there are things that, a member may be having a cancer journey, for example, and, they lose their hair. And, where can I find a wig? There's things that we can try and sort of anticipate for the member as well during the healthcare journey. And so really trying to ensure that as we sort of think about navigation and the various layers, that, you're getting the value at each layer. And I think ultimately, healthcare navigation, in the way I've described it as being clinical and non-clinical, provides that sort of value. And I think this also lends back to my statement that if you do it right, if you do healthcare navigation right, you ultimately are able to help the employer optimize their healthcare ecosystem. So that means making sure that the carriers hold their part of the bargain, making sure that the point solutions are driving value for your employees and that they're the right point solution for your employees. And thirdly, the members are getting the right care at the right time with the best advice or the best information available to them, so that they feel that they're heading in a journey that's going to derive the outcomes that they need.
Is it fair to say that navigation, at least at its most robust end of the spectrum, is the front door or the portal through which each individual accesses their healthcare and their health plan? So it's taking away the carrier, taking away the consumerism or the point solutions where the individual has to go kind of figure their care out and saying, you know what, we want to route everybody through the same portal, through the same terminal. And then from there, we're going to dictate, or not dictate's the wrong word, but we're going to help navigate where they need to go based on their unique situation.
That's 100% correct, Brian. It is that front door, whether it's digital or human, but it's also that front door that becomes the routine for member, that experience. That if they've had a good experience once, they should be coming back to that. So that's really important that when we think about the front door, that it's meeting the member at the point in time of their need. And also perhaps, anticipating future needs. So like I mentioned, somebody may be calling us because they twisted their ankle. They need to go and see a specialist. And then, we can at least sort of say, hey, well, you probably need to do some physical therapy. Here's other things that are important. And here's some information about, typically what happens with people like you, with the information around, their medical condition and what to expect. So really sort of becoming that resource and that front door is a very good and important analogy for making sure that this healthcare navigation is robust and meets the needs of the members.
So one of the past guests that I had on is a professional futurist, and she talked about how she and her colleagues are paying attention to different signals that are out there. Like what are the little signals that might turn into trends over time and have an outsized impact on the world? And so I've been sort of trying to pay attention to signals. And one of the things that I keep hearing is this rise of human-centered design. I think we are seeing it everywhere from, we saw it in our iPhones, and, why our iPhone and the user interface is so easy to use. It's so intuitive, right? It's just this design thinking, human-centered design methodology. But we're seeing it now move into human experiences as well. And I think the best example of it is the companies that have more successful return to office or I'll just call it post-COVID strategies for their employees and where they're going to do their work, were the ones that pulled their employees in, co-authored what the future is going to look like, took their feedback, built that feedback into whatever the plan is going to be. And that's it's what you're talking about before around social determinants of health. It's not just what are the healthcare needs, what are the physical needs of these people, but what are the barriers? What's the real world challenge that these people have to overcome to actually make this routine, make this part of their lives? And that's what we're talking about here with navigation too, is it's a human-centered design around how they access healthcare. So it's, hey, come in here through this front door, walk in through this front door, and then we're going to help guide you to an experience that's personalized for you. So it's funny how many different places in the world right now this sort of experience design and human-centered design theme keeps coming up.
Yeah, I think it's really important. And I think, you've hit upon some of the key elements is that how can we use signals to get engagement of that member? And then on the flip side, we also should think about why isn't somebody engaging with their healthcare as well? So starting with the signals that we do get that suggest someone's engaging in their healthcare could be manifold. It could be as simple as, what they're contributing to their HSA, HRAs. Could be simple as, especially during COVID, did people draw on their 401k to pay for something? So those are sort of early signals. And then obviously the social determinants of health, and how do we understand our employee populations, where they live, what's their access to care, what is their access to food, transportation, housing, etc., and how is that affecting them so that they can show up at work? And then, how is that helping them when they try to make healthcare decisions? And then on the tenets of, why aren't people engaging? We have to understand those barriers too. And some of them could be cultural barriers, some of it could be stigma, some of it's, DE&I, not, people sort of having a bad healthcare experience, and so therefore forever remain jaded and concerned about any future healthcare intervention. And then there's things like, people don't necessarily want to seek help. And so how do we get them to get help in an anonymous way, or a way that makes them feel comfortable? So, allowing them to have access to a digital solution may be one way, so that they can self-serve and make decisions or get information without sort of feeling that they have to talk to somebody. So there are a couple of things that are really important from a human design interaction perspective, for sure.
I like navigation. I've been talking about it with a lot of my clients, and I like it as sort of the next iteration of where we're going to try to combat a number of the problems that you talked about in healthcare. But there is a problem where this is great, but you need to have so many people in your health plan to be able to see the financial impact of doing these types of things. And for smaller and mid-sized employers, it can seem like a challenge to be able to do this. How large of an employee group do you need for this type of thing to have an impact on the cost piece of it? Because it's great. It's a great idea to have it impact all of your individuals and give them a better experience. But healthcare is already really expensive, and you've got a lot of business leaders already wanting to get out of the game completely, not wanting to spend any more dollars, or, shifting cost, or, making the plan less rich because they just can't afford it. Now we're going to go and we're going to add this other thing that's going to add some more cost up front. So where do you see navigation from a company size standpoint? And what do you suggest to smaller companies that maybe don't have the scale to see the impact? Or am I thinking about it wrong?
No, I think you're right. In terms of the employees, the size of the employer, I think it depends. When I reflect on how do we show savings and models of savings that bend the cost curve, a lot of the studies require huge masses of people to show that effect. And when I talk to colleagues in the analytics world, they talk about, really meaningful population size for an employer should be around 10,000 employees, which got me thinking is like, okay, well, that's probably good. That makes sense that, because the incidence of disease, of cancer is so low and, but it's a high cost condition, or the incidence of surgical disease is X percent. And therefore, the meaningful ROI on any model of healthcare navigation requires, a decent population to manage. So I think definitely the way we've constructed things, it's definitely been more towards the employers that have, 10,000. I probably even would say 5,000 employees and more. This is where it's potentially working. But then when you look at how many companies are below that, it's quite a substantial amount. And so how do we manage that? And so the question becomes plan design, and can you create economies of scale? And so I know that the carriers do what they do, but doesn't necessarily lend itself to driving healthcare costs down or providing value-based care. And so you're seeing companies come up that are providing almost a carve-out solution, doing their own sort of healthcare carrier functionality, but redesigning the plan. And the way they've redesigned the plan, for example, is to sort of offer essential care for free and only really sort of focus on the high cost piece if and when it's needed, which will be low, and providing it at scale across multiple employers rather than. And so I think there's opportunities in this small to middle size market where there's going to be a lot of pressure on the carriers to do better. And you're going to see and you're already seeing these third-party administrators that are growing in volume in that market space. And I think also the way those small employers are purchasing healthcare, they may be thinking of ways to fragment what healthcare solutions look like. So what you may be also seeing is having more direct contracts either with a primary care group or a healthcare system, or a telehealth solution that provides virtual primary care, for example. So you're getting some disaggregation of services away from what a typical carrier will be offering.
Well, and healthcare is just such a beast because there are so many different touch points, and there are so many different kinds of touch points and kinds of care you can get and kinds of medical conditions you can deal with, that there is no simple solution to the problem. And so on the one hand, we need to be sort of divesting from the traditional model, but at the same time, we need new technologies to come in and help aggregate that so that it doesn't become such a burden on both the employer and the employee, which is, I think, where navigation plays a big role, because you're now putting somebody in the middle who can navigate all the pieces for an individual. So we can still assemble a fairly complex offering, but it's not up to the individual to figure it out. We're gonna hold their hand and walk them to the right spot.
Exactly. And I think that starts to become a menu of options that meets the needs of the population of the employer.
This is a really interesting conversation. Is there anything we haven't covered when it comes to navigation or value-based care, or where you see healthcare going that you wanted to share?
I think value-based healthcare is hard. We've seen that in the Medicare programs. And I think this is an opportune moment for employers to lean in and demand it. And by that, I mean really pressure test the consultants that they have, pressure test the carriers, and sort of insist that this is what I want for my population. Can we think of a better way to design the solution? And that's benefit design, digital assets, human assets, the right navigation. Is the network right for me? I may have workers across the whole country and they have poor access. So maybe my strategy is to think of a hybrid model where I will offer telehealth primary care along with brick and mortar care that I will do direct contracting with. So we have to think outside the box of what traditionally has been done and demand value. And I think, the way employers are structured, from anywhere from small to large, we have this interesting opportunity, this inflection point, I think, in healthcare that needs to be addressed. And I think COVID has just really exposed a lot of the inefficiencies, the disparities, the issues around access, the issues of how we're paying for care. And so it's really sort of, I think we're at an interesting point in healthcare. And I really feel that working with employers, working with consultants, working with the carriers collectively, we can probably demonstrate huge value in what healthcare navigation looks like for employees.
I have a couple final questions, just a couple like quick hitters. When it comes to healthcare, what do you believe that might be a little contrarian to the masses or the current way of thinking?
I think we all feel like we know what population health looks like through data, through carriers, through consultants, through whatever. But the reality is people still don't get what they need. They still continue to have this harrowing healthcare journey that's troubled by the wrong financial incentives, and people are still paying for something they don't understand or control. So, I think there is that sort of gap that is forever talked about, but we need to take action on it.
What are you sick of talking about?
I think there's probably a lot of things. I think I really feel strongly that, the forever question of rising healthcare costs and no meaningful interaction, we just need a big push in that direction to make it, people to actually come together and collaborate and make it better. And I think we're getting small bits and pieces and small stepping stones, but we need a big bridge to walk across that chasm that I just described.
What in your mind would be the first step towards taking that big leap?
I think let's look at benefit design. Can I create a menu of options that make sense to the employer? And that evolves from financial incentives to solution services that are being offered, and what should be paid and what should be expected.
Well, Dr. Mistry, this has been a really interesting conversation and has me thinking about a lot of things, because as I mentioned at the beginning, this is the work that we do. So hopefully I and we can be part of the solution here, because I agree it's running at an unsustainable level now, and we're either going to fix it or it's going to break. And, hopefully we can fix it before it breaks too severely.
I agree. I think we can fix it. I think there's so much innovation and outside thinking around this. That's what is needed, really, because I think we can't continue the way it's always being done. And I think it is about looking at other ecosystems or other ways of doing business, and perhaps even other countries, how they view how healthcare is delivered, and using some of those concepts in our design of benefits and design of healthcare delivery.
Yeah. Well, and I always love reading stories of other countries, especially third world countries, where they just don't have the resources and they have to get creative on how they deliver care. I remember reading a story. I'm going to butcher the specifics, but it was essentially, I think it was in India and in rural India, and they were struggling with, amputees were really struggling to get prosthetics. And in the US, a prosthetic can cost $20,000 or more. And they, one, didn't have the money, and two, didn't have the high-tech materials there. And so this one gentleman, I think, used like milk crates and some other plastic elements and wound up creating a very high functioning, durable prosthetic. that they could sell for, a few $100s. And it wound up taking off and moving into other countries. And it was, was this very successful business. And I think you wind up seeing a lot of innovation from places where the box is really tight. There's a lot of restrictions as far as what your options are. And that's often where a lot of the best innovation comes out, because people have to get creative. And so I like that idea of, looking beyond just what we're doing here in the United States to, what are other people doing with some more financial and resource limitations than we're doing.
Right. Yeah, I've seen, I remember some anecdotal stories, especially in the Medicare population and countries where they're dealing with older aspects of their population. And so they've tried to look at, does it have to be a nurse that checks in on the patient to do a home visit? What about postal workers that are delivering mail to these houses? And, can, as part of their job is just a friendly hello. And, can you arm non-clinical folks with just some simple tools to perhaps give us signals that somebody's in trouble? So I thought that was really fascinating. And then, I had the privilege of going to the Geisinger system and looking at their food pharmacies. And just a little story about this is I got there and I was like, it just reminded me of when I was working on research in Haiti. And, just the power of allowing somebody to get better food and the joy in their faces and the support they received in getting the right food for their health condition was just so powerful. And it kind of struck me, in the US, we have to do this kind of thing. And yet it feels like we're still a developing country in certain areas of healthcare.
Well, I really appreciate you coming on the show. If people want more of you, we'll link to your blog and to Alight, where you actually offer these types of navigation services. And I would encourage anyone to reach out to me, and I can get you to other contacts at Alight. But thank you. Really appreciate you coming on and sharing your perspective. I think these are important issues, not just for employers, but for human beings who are trying to live better, healthier lives.
Yeah, thank you for having me. This was a great conversation and look forward to more.
Hey folks, one last thing before you go. If you enjoyed the episode, make sure to hit subscribe so you can stay up to date with future guests. That's it. Thanks for coming. Go make the most of your business and the people in it.